there is no other question. Thank you very much, Dr. Gargani, for your help and contribution. So
Thank
the
you.
next, thank you. So the next speaker is pre-recorded. Is Professor Feher. He's assistant professor cardiovascular medicine radiology in Yale University, and the topic is going to be advanced cardiac imaging in rheumatic autoimmune diseases. Okay, I repeat, the lecture is going to be pre-recorded, so we will not have any chance to get any questions to it. So let's proceed, please.
Good morning, everyone. First of all, I would like to thank the organizers for giving me the opportunity to talk about this important topic today. I know that you heard a lot about the cardiac MRI, the use of cardiac MRI in autoimmune rheumatic diseases, so I will try to focus a little bit more on other imaging modalities, but I will have to mention cardiac MRI, and there will be some repetition, but it's really an honor to talk to you about this topic today. For my disclosure, I have two career development awards that are related to cardiovascular imaging in rheumatology conditions. So, the outline of my talk first, I will talk about the cardiovascular risk in autoimmune rheumatic diseases. I will talk about cardiovascular imaging, including briefly mentioned echocardiography. I will talk about calcium scoring CT, coronary CTA, PET myocardial perfusion imaging, and cardiac MRI, as I mentioned briefly. I invented this little graphic to help you to navigate whether whatever I'm talking about is available in routine clinical practice. With the green check mark, will mark things that are widely available. The yellow check mark is when it's available in limited centers, and this red time icon is really for future applications that are not currently used. Also, at the same time, I will start with going large with perfusion imaging, and then I go deeper and deeper into microcirculation and molecular imaging. Well, I will mention molecular imaging. So let's dive in. So when it comes to cardiovascular risk, I think this is a really important paper. Many of you will be familiar with this paper. This is a UK based study looking at patients. It's a retrospective cohort study looking at 446,000 patients with autoimmune disease, and they matched them with controls. And this paper nicely demonstrated that any kind of autoimmune disease is associated with cardiovascular risk. But however, those with lupus, systemic sclerosis, Addison's disease, and particularly those who have three or greater number than three autoimmune diseases are at the highest risk for cardiovascular disease. It has been known for a long time that rheumatoid arthritis has a very similar cardiovascular disease risk, which is comparable to diabetes without rheumatoid arthritis. And for when we talk about why these autoimmune diseases have increased cardiovascular risk, it can be due to the presence of traditional risk factors such as hypertension, diabetes, obesity, or smoking. It can be their association with cardiac involvement, and systemic inflammation is a main driver of atherosclerotic disease. And sometimes it could be related side effects of medications such as steroids, which are really devastating. And many times it's underappreciated how sedentary lifestyle with autoimmune disease due to arthritis and pain and depression can contribute to this finding. When it comes to prevention guidelines, the newest U.S. prevention guidelines published in 2019 highlight the role of inflammatory diseases such as rheumatoid arthritis or psoriasis as ASCVD risk enhancers. So it's more and more recognized now that these diseases indeed present cardiovascular risk. And this is nicely coined by Dr. Whitaker, the residual inflammatory risk. If you have a patient who has high LDL and high CRP, you put them on high intensity statins, some of these patients will have remaining elevated cholesterol. This is With residual cholesterol risk, these patients need additional LDL reduction. On the other hand, there are patients, such as these autoimmune patients, who have residual inflammatory risk. Despite being on statins, their CRP remains high and they need additional inflammation reduction. And it has been shown nicely, both in the Prove It and the Improve It trials, that those patients who have both elevated LDL and high CRP will have the highest rate of events compared to those who have only one of these or none of these findings. And it's a nice in this nice era we can talk about all different risk, and with the residual inflammatory risk is usually considered when the CRP is greater than 2, and we have newer therapies coming out for targeted inflammation reduction, and the most important one at this point is colchicine, which will reduce future cardiovascular events in patients with increased very high risk for atherosclerotic disease or those with a recent myocardial infarction. So, what is the cardiac involvement in autoimmune diseases? Because I think first we have to talk about what is the involvement, and this is a scleroderma paper, but I think it's nicely demonstrates the different kind of avenues that can be addressed here. So, cardiovascular autoimmune diseases are associated with increased risk of atherosclerosis, coronary microvascular disease, and also among vascular complications, pulmonary artery hypertension, Raynaud's syndrome. The myocardium can be affected, so it can be associated with myocarditis, pericarditis, and it can be associated with fibrosis and arrhythmias. And all of these can lead to heart failure, which can be systolic or diastolic heart failure. So the entire heart can be affected by autoimmune disease. And multimodality imaging is really a nice way of showing all these involvements. So these are two recently published expert consensus documents. The one is read by Sophie Mavroghani and the other one by Brittany Weber, which really highlight the nice complementary value of multimodality imaging. We'll go with which imaging modality, which part of this pathophysiology can be tracked and investigated. So I really urge you to dive deep into these manuscripts. They are really excellent documents. So I'm not an echocardiographer, so I won't talk about echocardiography as much, but but for echocardiography, I just would like to highlight the importance of the diastolic dysfunction evaluation, the right ventricular evaluation, and the global longitudinal strain evaluation. But echo is really the bread and butter and the first imaging modality that we usually use to assess these patients, and it's non-invasive, it's cheap, so this is the first step that your patient should get. And we could argue that most of these diseases should get an echo and a routine echo at some point in their journey in their disease. Echocardiography can be used to evaluate myocardial blood flow with something called a myocardial contrast echocardiography. This is done by the injection of microbubbles and destroying these microbubbles. However, this is not routinely used. It's available in some centers, but not made it to routine clinical practice. You can also assess coronary flow velocity reserves. If you have a Doppler probe and you're able to find the LAD, then you can track the LAD and you can get the flow velocity reserve in response to certain stressors. It can be adenosine, ATP, or regadenoson. You see increase in the flow in the LAD, and you can calculate the flow velocity reserve. And this paper nicely showed that patients with lupus, systemic sclerosis, or RA have reduced coronary flow velocity reserve. However, again, this is very angle dependent. You have to have an expert sonographer or an expert who knows how to get the LAD always in the same angle. So it's not trivial to perform. However, it can be useful. Not available in all centers. Coronary calcium scoring CT is routinely available nowadays, and it has been shown with multiple publications that patients with autoimmune disease, such as this one, published by Mortens and his group, that 4,000, roughly 4,000 autoimmune disease patients, that autoimmune disease increases the risk of having calcified any coronary calcification or having coronary calcification above the 90th percentile. And this autoimmune disease in this population is associated with adverse outcomes. So many times you can get non-gated, non-contrast chest CTs in these patients. It's done for other reasons. For example, it's done for interstitial lung disease. So I strongly recommend to open these images and find look for coronary calcifications. In this case, this was a 67-year-old woman who was referred to me for evaluation of coronary calcifications, and this was the coronary calcification. And I can trick the system to get it in the software, as it's not a CAT scan that is done with all the requirements, the slice thickness and the breath hold as done with a regular calcium scoring CT. However, you can still get an estimated calcium score. And in this case, this patient had an observed calcium score of 285, which is at 89th percentile. And I was able to have a discussion with this patient, and I was able to convince her to start statin therapy. Some AI tools can also assess coronary calcification. And this evaluation of non-gated, non-contrast chest CT, even just by visual assessment, should be available in all centers. As I said, AI can be used to evaluate these non-gated chest CTs in inflammatory disease patients, and this is a publication that is hopefully soon come out from Brittany Weber, showing that if using AI to quantify coronary calcium in non-gated chest CTs, and she nicely demonstrated that an increased calcium score is associated with increased risk of MACE and also all-cause mortality in these patients. This AI assessment of calcium is not available in all centers, but I think it's getting more and more popular. Why is it important to quantify calcium? Well, this paper nicely demonstrated that in patients to be on the left with comorbid rheumatologic diseases uh, and diagnosed prior ASCVD, even in the presence of ASCVD, 37% were not on any statin therapy, and only 30% were on high intensity statin therapy. And this was significantly higher rate of patients not on any statin therapy when compared to controls without any rheumatologic issues, which was 28%. Okay. You can also do coronary CT angiography. So in this case, this was a 63-year-old patient of mine who had rheumatoid arthritis, hypertension, hyperlipidemia, smoking, who was referred to the cardiology clinic for a pre-operative knee replacement. And she had an abnormal EKG. So I sent her for coronary CTA. And as you can see, the right coronary on the left looks normal. The circumflex coronary has some small calcified plaques or mixed plaques without any significant narrowing. However, the diagonal coronary here in the middle had something, a mixed plaque causing a moderate stenosis. In the old days, we would have sent this patient to the cath lab for evaluation. However, now we can do compute CT-FFR. CT-FFR is basically fluid dynamics done by a company. We send the images and they give you these beautiful pictures. And in this case, the FFR, CT-FFR is significant if it's 0 0.8 or less. And in this case, it was 0.91. So it's showing that this stenosis is not significantly it's not hemodynamically significant, so we didn't need to take this patient to the cath lab. And this should be available in most of the centers. We can go one step beyond and we can analyze the plaques themselves, because the CT sees beyond the coronary lumen, unlike a coronary angiogram. And here you can see that a lot of publications have demonstrated that patients with autoimmune disease have higher rate of non-calcified plaque, mixed plaque, and calcified plaque. And the first one was in rheumatoid arthritis, but it's also true in lupus, where actually the non-calcified plaque volume is significantly elevated. And in the US right now, this is covered by Medicare and Medicaid, so it's covered by the national insurance. So we're more and more getting these requests to quantify plaque. However, I think we're still quite in a premature stage to know what to do with these results when we get it, how to follow it, how would it change management for the patients. And this is available in most of them. It could be available in most of the centers. So we talked about the epicardium. Let's go one step beyond the microcirculation. Well, the microcirculation is one step beyond. So we can see with the coronary CTA the spatial resolution. So where you can differentiate two dots from each other is 600 micrometers. So the microcirculation starts below that. It's anything below 500 micrometers. This is where most of the blood volume lies within the myocardium, and also this is the site of resistance. And as you can see, the spatial resolution of SPECT is 10 millimeter, PET is 5, the MRI is 1 millimeter, and the CT is the best spatial resolution, 0.5 millimeter. When we talk about sensitivity, the PET and SPECT tracers are the most sensitive in the nanomolar range, whereas in MRI and CT, you have to give higher concentration to see the image area. So the good news is with CT technology is rapidly evolving, and now we have photon counting CT, which has ultra high resolution with up to 200 micrometers, so 0.2 millimeters. In this case, this is a courtesy of Dr. Lucia Parik. This is a photon counting CT of the 59-year-old man with diabetes, dyslipidemia, and ankylosing spondylitis, had a really high calcium score of 988. And look at these gorgeous images. So they were able to get beautiful images of for this patient, and you can see the coronaries extremely well, even in the presence of really high calcium. So this future technology not available everywhere, but it's getting more and more common. And I think I expect it in the next 5 to 10 years, this will take over coronary CT imaging. While coronary CT sees beyond the vascular wall, and we can see the perivascular fat surrounding the coronaries. In the past, we thought that the vascular tissue is is very productive, so it can produce a lot of cytokines that can affect endothelial function. But it's true the other way as well. If you have an inflamed endothelium, it will affect the perivascular fat. And this is the group from Oxford who developed this something called a fat attenuation index. And the fat that is surrounding an inflamed endothelium, inflamed area, has more positive, so less attenuation when compared to a healthy fat. So here you can see that patients in this was done in psoriatic patients where patients on biologics had more negative attenuation fat, so healthier fat when compared to patients with not on biologics. And also when they followed the patients after 1 year biologic therapy, fat attenuation significantly decreased over time. So it's a very exciting thing. I don't think it's available in most centers, but it's going to be exciting to see how this develops. And again, Dr. Weber did a study where she showed in patients with psoriasis, rheumatoid arthritis, and lupus, the fat attenuation index is associated with major adverse outcomes. So when it comes to evaluation of the microcirculation, we use routinely in the US PET myocardial blood flow quantification, and many European centers employ this as well. And what we do here, the half-life of the used tracer, in this case rubidium, is very short. So what we do is we image the patient while the patient in the scanner. So we'll start this video, and we follow the radio tracer. Goes to the right side of the heart, right ventricle, right atrium, left atrium, left ventricle, and finally it gets trapped inside. It gets extracted in the myocardium. And you can see, follow these curves. This is the arterial input function curve, goes up and comes down, and you can see that the other lines where it gets trapped in the myocardium. And if you have these curves, you can calculate myocardial blood flow with using kinetic modeling. In this case, you see that the perfusion imaging in this person was normal. However, when we looked at the myocardial blood flow, the stress myocardial blood flow was reduced to 1.89. Normal is greater than 2, and the myocardial flow reserve was also abnormal, which is stressed myocardial blood flow over rest myocardial blood flow, and was 1.65. The normal should be greater than 2 as well. All right. So a lot of data is out there about the use of PET myocardial blood flow quantification in the autoimmune disease population, in rheumatoid arthritis, lupus, systemic sclerosis, psoriasis, and multiple combinations. Well, one thing that is common in these papers is that patients with autoimmune disease commonly have reduced myocardial flow reserve, as indicated here. However, what is also interesting is that the reason for the reduced flow reserve is many times not the increased reduced stress myocardial blood flow, but the increased rest myocardial blood flow demonstrated by multiple papers. What is the meaning of this? I'm not quite sure. They probably have baseline hypoxia or baseline conditions that increase the rest myocardial blood flow. However, regardless of whatever is causing the reduced myocardial flow reserve, it's predictive of outcomes, nicely shown by Brittany's group. And we also demonstrated this, showing that patients who have both autoimmune disease and reduced myocardial flow reserve do worse than those who only have one or none of these conditions. The good news is the PET myocardial blood flow quantification is now not restricted to centers who have a high PET volume. There's a new radio tracer called Flurpiridaz, which has higher spatial resolution, really high spatial resolution, high half-life, and this higher half-life makes it possible that you can have unit doses and does not require on-site cyclotron or generators. So it really opens up the possibility of doing PET myocardial blood flow quantification in centers where otherwise it would not be possible. It's not available everywhere, but I think it's something that you can consider if you don't have a PET program already. Another thing that you could think about is myocardial blood flow quantification with CZT SPECT. CZT is a high sensitivity, reduced noise, and minimal signal loss SPECT technology, solid state detectors, no rotation required. Therefore, you can put the patient in the scanner and acquire dynamic data. So you do similar data acquisition as with PET, as I showed. You detect the peak, up peak, and the coming down in the blood, and the extraction in the myocardium, similar extraction curves that I showed you before. And you could use this for myocardial blood flow quantification. For a caveat, I have to mention that the tracers, the currently available tracers, are not exactly ideal for myocardial blood flow quantification, so the flow might be underestimated, especially at high flow rates. And the normal values for coronary microvascular disease is not exactly well set. Okay, so this is not available. Obviously, you have to have CZT spec and you have to have the technology established if you want to use it. Next step is PET molecular imaging, which is really the future for imaging atherosclerosis and other cardiovascular involvement. You can image glucose uptake, especially in the aorta. You can image vasculitis. You can image microcalcifications with sodium fluoride. You can image somatostatin receptor 2 on activated macrophages. And you could image CXCR4, which is expressed on activated immune cells. Again, these are exciting agents for the future to image inflammation. Most of them are not available except for FDG, of course. Another exciting agent is gallium FAPI, which can be used for imaging myocardial fibrosis. This is image. These are images for a patient with systemic sclerosis, and you can see that patients who had fibrosis had significantly higher target to background ratio, SUV max. So basically higher uptake in the areas of fibrosis. And they have shown in this case report that patient who received CAR T cell therapy, the FOPI uptake improved over time. So very exciting, not routinely available everywhere. So then I would like to talk a little bit about the use of MRI in systemic inflammatory conditions. As you probably heard about it, it's the gold standard for LV and RV systolic function. It can be used to evaluate pericardium, valvular heart disease. You can assess edema with T2 mapping. Myocardial perfusion with stress MRI is really evolving. And then you can image myocardial fibrosis, scar, and inflammation with with LGE assessment and T1 mapping and ECV calculation. This is should be standard, and and T1 mapping should be really the should be really used in all of these MRI images when you're imaging ARDs, nicely highlighted by this consensus document. And whenever it's possible, you should calculate the ECV. And this was images for one of my patients who had elevated ECV and elevated T1 with systemic sclerosis. Um, MRI can be useful for the evaluation of MINOCA, where you can classify patients presenting with MI with non-obstructive coronaries. And this study was done within 10 days and identified myocarditis, Takotsubo cardiomyopathy, or normal findings in many of the patients, in addition to true MINOCA. So this can be really helpful. And this is a common presentation in our patients. You can do with CMR, you can do perfusion imaging, viability assessment, and functional assessment is very helpful. It's perfusion MRI is not available everywhere, and you can do quantitative perfusion similar to how you do it with PET myocardial blood flow quantification. You can quantify blood flow with stress MRI, with rest, stress, and myocardial flow reserve. And again, this is not trivial to set it up. You will have to spend some time if you want to really quantify blood flow in your during your stress MRI. And why is it useful? Or if you have someone with normal perfusion and globally low myocardial blood flow, then three scenarios you can consider is inadequate stress, a microvascular disease, or severe triple vessel disease. So these patients would need to go to the cath lab. So I think this is very helpful in addition to just perfusion assessment. It has been used in the autoimmune population. This study showed that in rheumatoid arthritis, there was really no difference in after therapy in baseline and 1 year therapy myocardial perfusion reserve and also stress myocardial blood flow. However, this paper showed that patients with systemic sclerosis has significantly lower stress myocardial blood flow and myocardial perfusion reserve when compared to controls, and this is shown by MRI. We could also use MRI to image the coronaries and use high resolution MR angiography. However, this is really the future. These are gorgeous images. Compare the CT images to the MRA images, and these look fantastic. This was done in a 5 Tesla. This is mostly in the research setting for now, but maybe in the future we will be able to have these nice images free of radiation, which is a huge advantage of MRI. So in conclusion, I hope that I was able to demonstrate to you that multimodality imaging, cardiovascular imaging, can help to characterize cardiac involvement in these patients with autoimmune rheumatologic conditions. You could use coronary calcium scoring, CT, non-contrast chest CT, and coronary CTA with plaque analysis to really assess whether there is atherosclerotic plaque in the coronaries. Fat attenuation indexes is a very exciting tool to track perivascular inflammation. I think the jury is still out to see if this could be used in routine clinical practice. A lot of techniques can be used for myocardial blood flow quantification, including myocardial contrast echo, PET, potentially CZT, SPECT, and stress CMR. I think these are exciting times when we can see just beyond perfusion, and we can actually quantify how much blood is going to the myocardium, and we have the chance to diagnose coronary microvascular disease non-invasively, which is a huge thing. And then finally, cardiac MRI is the undisputed gold standard for volumetric quantification and tissue characterization. So please use it in this patient population because it's a very helpful tool. So with this, I would like to thank you for your attention to listening to talk, and I just would like to thank my team at Yale, the cardiology and radiology team, and also the cardiorheumatology program at Yale, which is really a wonderful group of people, and with aiming to help rheumatology patients within a multidisciplinary team for their cardiovascular care. And we have a really great model to see these patients, to co-manage these patients with the rheumatologist. And if you don't have a program already like this, then I would strongly encourage you to consider it. Thank you for your attention.
Hello to everyone. Um, so, okay, so it was a great talk. So we have to inform you that unfortunately, Dr. Hillier will not be with us, probably due to a problem that holds her back. We're going now to ask the audience if they want to comment anything, and we can have a short chat on this, and then we will proceed summarizing this session with my co-chairman, Dr. Benitez. So if there's, yeah, yes.
I just want to comment on the CT. I mean, in our routine practice, we don't use all these applications, which is pity because there are very important applications of CT that could be of value for rheumatic patients, such as fat attenuation and also FFR, which we should try to include it in our everyday routine. And the application of CT in rheumatic disease allow us to see the difference between the plaques in systemic lupus erythematosus and rheumatoid arthritis. And in a recent paper, it was identified that plaques in lupus have a faster progression compared to plaques in rheumatoid arthritis. And this explains a very aggressive presentation of CAD in lupus. So all these informations are very important, and we can get it without intervention, and we can repeat it anytime we want, just because now the radiation amount is very small in CT. So it's a good opportunity to get the profit of all
I'll make
this.
a comment also on that.
Yeah.
I think firstly, I was impressed from all the imaging modalities that were summarized in this talk. First, I would like to say that we can always quantify calcium from non-gated CT, as Professor Feher already mentioned, because all these patients with autoimmune inflammatory disease undergo very often for their interstitial lung disease chest CTs, where we can risk stratify these patients, taking into account how much calcium there is. Secondly, I can say from everyday clinical practice that there are many cardiologists now that are sensitive enough, and they are sending patients because of autoimmune rheumatologic disorders such as rheumatoid arthritis or systematic lupus erythematosus for cardiac CT. Because it's considered a risk factor for coronary artery disease. So there is some sensitivity regarding this topic, and there are many patients that come to cardiac CT because of a history of autoimmune disorder.
Okay, thank you, Dr. Benetas and Dr. Mavrogianni. Yes, I agree with you that these talks were very comprehensive and very informative for the imaging capabilities that exist nowadays, like on rheumatic disease. And we can see how we can start from echo, that it is a low cost and very versatile modality and very cheap one, and we can apply to all patients, and now we can get information with the addition of the strain analysis about the stiffness and the condition of the heart, and we can get also information about the diastolic function that, as we said, is the first thing that normally is affected in cases that the myocardial stiffness started having problems. So, and as you very successfully commented on the CT, that it is a new technique, and now it is very developing and can give us information about all the inflammatory status and anti-rheumatic disease. I was impressed by the connection between the rheumatic disease and the LDL in the last talk. That, and on top of that, MRI always will be the cornerstone in the detection of inflammation. And I would say I would like to have like a comment here that normally most doctors, MRI doctors, face the autoimmune disease as like a unified group of diseases. for the MRI. So it's not, because if we go further, now there are studies that it's different. It's different disease cause different in the LGE. So the thing is that we have to mention not only that there is an inflammatory disease, there is something like autoimmune background or whatever, but we have to comment on the specific findings and to which specifically autoimmune disease is most likely related. We cannot get any information and any diagnosis, but we must comment that the findings are in keeping with this disease or the other rheumatic disease, because as I said before, there are different patterns for different rheumatic diseases. So I understand that Dr. Mavrogianni is busy. So Dr. Benetos, if you don't have any other comment, I can see from the control, Dr. Benetos, that there are no questions. So if Dr. Mavrogianni is happy, if you are happy.
Yes, I am happy. And I think you summarized everything, both of you. You were ideal chairpersons, and thank you very much. I think we should leave some time for a break, for a short break, and 11:30 we can start again.
Thank you very much.
Thank you all.
Except in case you have to add something more, I don't know.
Nothing appears here.
Thank you.
Okay.
Thank you very much.